what I'll try and do is really raise some of the issues about why I think, and those of us who do this sort of work are very committed to looking at what we can do about giving all infants and their families as early as possible a good start to their emotional and psychological life. In other words, we're seeing the importance increasingly in terms of what we know about early development, but what we can actually do in these early years of promoting healthy care for infants, giving infants that best possible start so that they become resilient and they're better able to cope with the inevitable stresses of life. And there are many factors, of course, in our communities and societies, particularly if we think of the current times we're living in, where caring for children and babies and really protecting them in the way that all parents want to is quite challenging. People are stressed for various reasons, whether it's because of the pandemic, whether it's social factors, financial pressures, breakdown of families and relationships, let alone some of the bigger issues that are going on in terms of community-based violence, and even internationally, some of the horrendous atrocities that we're seeing, which are also very much affecting children and even infants in somewhere like Ukraine. So these are very hard times. Parenting is never an easy process. It's a process of where people learn about their baby, how to cope with their baby, but most parents are extremely well motivated and are wanting to provide the best they can, even if they're in these very adverse circumstances. So fundamentally in perinatal and infant mental health, we're focusing on the earliest developmental periods. It's a broad focus. So just to define the territory, we're looking at emotional and psychological well-being of women, infants, families, and that using that in the broadest sense of the term, whether that's community members who are important in the life of that infant, whether it's biological co-parents, partners, significant others. I think we have to accommodate the diversity of important relationships that can surround children. Some families will come and consult us about should they become parents. They might be worried about particular issues in their own backgrounds or histories that they feel will be challenges for them. So we can be involved from a preconception thinking about becoming a parent as a very important psychological decision. But we generally care for parents, potential parents through conception, throughout pregnancy and early childhood, variously defined. Some people stop at 3, others would say, well, it's the preschool period. It's largely artificial. Of course, we're interested in those very early developmental processes where parents and carers around a child are the core caretakers and fundamentally important to their development. So there are common issues of psychological adjustment and in becoming a parent, which we define as adjustment issues in the transition to parenthood. What sort of parent does someone want to be, and what are the challenges to that? If someone themselves has had a difficult beginning and suboptimal parenting or difficulties in their own family, how would they like to change things, to do things differently with their own child, and to be able to provide their child maybe with some of the experiences that they weren't able to have because of circumstances. And obviously in some community groups and cultural groups, these are very important issues. There's something very powerful about a generation who've experienced trauma and loss, being able to parent effectively with their own children. And we certainly see that in various groups of people within Australia and those who have arrived in Australia from situations of trauma and conflict, the importance of passing on positive growth experiences to the next generation. In our work, we also see and treat some families affected by various forms of mental illness and mental disorder, in pregnancy and in the postpartum period, so after the birth of a child. And occasionally those are families who will benefit from inpatient care, such as in a parent-infant unit, or outpatient programs, which can really support that parent in their recovery from mental illness and anxiety, but also support their recovery in terms of having a good and positive relationship with their infant, which supports infant development. So this is a very important group when we're thinking about mental health services across our community. And as we're approaching yet another election, this is a good issue to raise at every possible opportunity, that good mental health starts at the beginning of life, if not before. It starts in utero, but certainly the beginning of life is fundamentally important. And some parents might have challenges to parenting in the way that they would like to, and services have, from my perspective, a responsibility to be able to provide that level of support that actually acknowledges that people with mental illness and mental disorder can be effective and very positive parents, and often improve in terms of their own mental health and adjustment in being able to really achieve something positive with a child. So we tend to have very romantic notions of what goes on in early childhood. This is just a nice Mary Cassatt painting, quite romanticised, happy mother staring lovingly at the child and so on. It's a beautiful piece of work. But many of the parents that we see have significant challenges in their lives that make these sorts of moments, much as they would like to provide them for their child, quite fleeting or not very common, to say the least. So the concepts that we're working with is that becoming a parent, firstly, and being pregnant is a major stress for anyone's life. Becoming a parent, particularly for the first time, poses a lot of psychological and physical demands. It impacts relationships around the person who is pregnant. It can affect, both in a positive way and negative way, broader families and broader communities. There are certain risk factors for people who have pre-existing mental health problems, who might need extra support in actually coping with pregnancy and having a baby. And there are risk factors in some communities where relationships break down under stress very easily, or are poorly resourced or isolated, who don't necessarily have access to the sorts of mental health services that we would like to see. So the range of mental disorders occurring in this period are actually very broad. Everything from mood disorders, so largely depression and anxiety, occasional postpartum psychosis, which is a particularly severe but not common condition. And then we have people who are suffering from mental health problems who might actually have an increase in symptoms during a pregnancy or in the postnatal period. It's very important that clinicians in general mental health services are aware of these sorts of conditions and can really inquire in a sensitive way about how a person who has mental health issues is thinking and feeling about their pregnancy or being a new parent, and inquire about what level of support they have. We need to always, in mental health, of course, look at people in their context in terms of their community and family supports. A lot of people who are suffering from psychosocial vulnerability and high levels of current stress have difficulties with pregnancy and early parenting, and can be quite easily overwhelmed by that. Relationships sometimes break down if partners and significant others feel they can't cope with being a parent themselves, or can't support the primary carer of the child. And sadly, we know that relationships in trouble can often get worse during pregnancy. The best known and cited example of that are the high rates of domestic violence of first onset during pregnancy in a troubled relationship. Deeply concerning, both in terms of obviously the effect on the mother and but also in terms of the fetus and the pregnancy. And these are high risk situations in that mothers are very stressed. Obviously they're in a violent and rejecting relationship. So again, all the more reason for having services like pregnancy care services, being able to ask the questions, whether a woman's safe, does she have any concerns about her relationships, does she have enough support? So any of these mental health issues and stress issues occurring in such a vulnerable time can have long-lasting effects. And maybe that's one of the very important reasons that we want to get better at identification and intervention. So mental health issues in pregnancy can have effects on the infant-parent relationship and family functioning when the baby's born, and broader effects going forward on infant development overall and the functioning of family groups. So that's the rationale for doing what we would like to do during this period. There's increasing science and evidence about the importance of the first 3 years of life, which we use in thinking about what sorts of interventions might actually be helpful. So in the first 3 years of life, we know a lot more currently about the importance of infant brain growth and psychological and emotional development. This is the time when our brains are growing at their most rapid rate in the lifespan, which is very significant. We also know about how mood and anxiety, mood disorder and anxiety issues in a parent can affect the quality of care, and that will then have an impact on infant development and their sense of having a stable and available attachment figure. All these things are very important in terms of thinking about resilience in infancy, having an attachment figure who generally responds and is available, at least one attachment figure. Some infants are lucky to have multiple attachment figures. But having someone who is available, who's not totally feeling so unwell that they're preoccupied with their own issues is very important for infants. Sometimes depression, if it's not recognised, can be a long-lasting condition, say for the first 12 to 18 months of a child's life, and that can have longer-term consequences for development, as well as leading to increased risk of depression in that child as they get older. So a lot of reasons, if we wanted to list them, which we won't today, but just to be aware that there are many good arguments for getting in early as a preventive approach. So this is an approach that at the recent Royal Commission into Mental Health Services in Victoria, that several people who are giving evidence stressed the importance of looking at this time of life as essentially one about the earliest intervention or true early intervention and an opportunity for prevention of really significant later mental health problems. So I'm not sure that I can offer more of a rationale for it, but I think that's pretty good. That's just to show you the brain, how it's growing rapidly in the first 3 years and then plateaus. So growth is the most rapid right at the beginning. That's what it looks like in terms of the density of connections between nerve cells. And this one just shows you the dark areas of brain activity. So the 1-year-old child has got a very active brain. It's actually more active than the adult brain, the 28-year-old brain. That's just a quiet, resting brain. So it's quite interesting how much of the world and experience babies' brains are processing and literally laying down in the actual developing brain. So this, we've said that there's a whole range of mental health problems that can occur in this period. Lots of theories, which I won't go into, but whether this is hormonal, the physical components, the stress of pregnancy, obviously these are important. But there's also a whole lot of environmental factors, psychosocial factors, and historical factors in the lives of potential parents that can make parenting challenging. Also, we tend to use the term postnatal depression to cover everything, even though postnatal depression is usually a mixture of depression and anxiety, and it can usually commences in pregnancy. But that's become a very useful focus of thinking about services, and everyone knows, and a lot of government work has gone into raising awareness about, oh, sorry, I'm going backwards. raising awareness about the importance of postnatal depression. All right. Baby blues are not a mental illness. I think it's important to say, and this might be the best example that we have of hormonal changes, as well as getting used to just having had a baby. If something occurs in normative, healthy pregnancies and deliveries in up to 80% of new mothers, it's very difficult to call that anything out of the ordinary. So most of these do resolve pretty closely. If we're going to do preventive work, I guess what we see quite frequently are issues, as I've stressed before, about becoming a parent. What does it mean to be a good enough parent? And partly this involves seeing oneself as competent and being able to care for someone else, in this case a dependent baby, dealing with the frustration that can go along with that, thinking about relationships and changes in relationships, like with work identity, partners and so on. So counselling around these issues can be very helpful for people who are concerned or getting some degree of anxiety about their capacity to cope with the changes. But there are some groups of parents, potential parents, we might want to actually have focused services for. People who are solo parents, because that's a very demanding undertaking. People who are either very young, by very young I mean young adolescents, who I might see some of, who are 13 or 14-year-old parents. This is a very, hopefully not that common, but is quite a very demanding thing. The so-called older parents, depending on how we define old, but in obstetrics, that can really be anyone who's in their 40s. And increasingly, we're seeing people with a whole range of different experiences using technology, IVF being the most simple, but quite complex arrangements for actually becoming a parent, like surrogacy arrangement, 3-person babies, leaving aside, the issues that go along with discussing that. These are increasingly available and of great can arouse a lot of anxiety. So some people might need extra support. Just to identify some of the risk factors, and again, all clinicians in mental health might want to know, and if someone tells you that they're thinking of having a baby or they've experienced some sort of parenting difficulties or even postnatal depression in the past, we need to do a risk evaluation to see what support they might need. So people, for example, who are at risk of developing postnatal depression and anxiety are more likely to have a past history of some mental health problem or a family history. So they might say, well, my sister, my mother, my grandmother all had very severe postnatal depression. Am I likely to get it? That's a good question. We can't give exact figures, but we know they're at increased risk. Are they unsupported? So are they sole parents, refugee experiences, people in difficult, current, stressful life events? And then if they've actually had a baby, have they had complications or traumatic experiences actually having a baby? Or they've had a baby who's either premature or has been unwell. So all those sorts of factors have an influence. And actually, when we meet people in the real world, they often have a lot of these factors coming together. So it does make it a risky time. They might have ongoing problems in their relationships, and very significantly, they might have had early trauma or poor early family relationships themselves, which is more likely to make people feel anxious. They don't want to have difficulties in their own parenting, but they're concerned that they might repeat patterns that were negative for them. So those sorts of risk factors can actually be identified, and probably very important that we focus on that. Anxiety disorder, I won't go into in great detail, but these are very common. Experiences of anxiety during pregnancy are common, and some are very normative. Commonly experienced anxiety about, is my baby doing well? Becomes a bigger issue, let's say, if someone is on medication for mental health issues, or they need to take an antidepressant, which occurs for some women, but not all. They might have very understandable anxieties about the role of medication in pregnancy, and we need to have expertise around our systems to have those really focused discussions with women about the safety of antidepressants if they need them, when they can manage without an antidepressant, but importantly, how to deal with their own symptoms, and to understand that anxiety can, in and of itself, can have impacts on babies' growth in utero. High levels of anxiety with all those stress hormones are not good for babies' development. And then we sometimes see, largely in hospital settings, people with quite severe anxiety disorders, which can get worse in pregnancy if people, particularly if they've had that before, something like obsessive compulsive disorder, for example. So there's a whole range of different conditions that I said. A rare one, just to be aware of it, is that we occasionally see postpartum psychosis, so very severe mental health problems, not commonly, about 1 in 1,000 deliveries. And again, a very frightening experience for women who might find themselves in an acute mental health unit. What's important about those conditions is that they're obviously treated as rapidly as possible. They can occasionally develop into or prove themselves to be a form of ongoing bipolar disorder most commonly, and they can be associated with a very high rate of relapse in a subsequent pregnancy. So what that says to me is that services need to be able to provide proper support in establishing a relationship with a baby if that's been disrupted right from the beginning. And parents are often deeply troubled by what they've been through, quite traumatised by the mental disturbance that they've had, wanting to provide the best for their baby and need some support in doing that. So that might be a good role for mother-baby units, so actually caring for parents who've been through those experiences. And I currently run mother-baby groups for women with mental health issues, and we have 3 mothers who have recovered from these sorts of conditions, because they usually do recover, thank goodness. And we're working on their relationships with their babies. And it's really a very satisfying role for clinicians and our staff, but also for these mums to regain a sense of their competence and confidence as a parent, even in the face of having had really significant symptoms. And, you know, I'm pleased that we can actually do something to help them in that condition. I won't go on about the drug issues. If anyone has any questions, you can ask about that. Oh, sorry. But they can be used. There's a whole lot of increasing evidence about them. And the same with antipsychotics, if anyone has any questions about that. But all these things do need careful explanation to families about the appropriate use of these medication, appropriate monitoring. It's not just a matter of throwing, I shouldn't be so flippant, but just giving medication without the proper supports of the significance of it and the emotional impact that making decisions about whether to take medication or not has on the families that we're seeing. Very important to address that. People often have questions about breastfeeding if they're on various medications for mental health reasons. And obviously, the principles are that there's always a risk and benefit analysis that we need to do. Some babies are affected by the milk that has medication in that. There are some techniques that are used to modify the amount that they're exposed to. But if it's essential for keeping a mother well, then we have to look at that. So all of these, there are many, I guess, conditions that can affect how mothers are functioning at this time. Significantly, our focus is, yes, on the mother and family, co-parent and so on, in terms of maximising their mental well-being. and their psychological sense that they can be effective parents, but we also hold in mind the baby. So if we're looking at someone this age, they obviously need someone who's there for them. They're incredibly expressive, and someone needs to be able to respond to that. So some of the techniques that we use in this sort of field for getting relationships back on track is to help parents who might have been struggling to actually look at faces like this in their own baby. This is just a nice little baby who I found online, but you know, very cute, very expressive face. We could all have a go at naming the emotions being expressed. Some are a bit more puzzling. But what's important is that there's someone there, and you can see that baby's looking outwards. There's someone there looking at that baby and trying to work out what's, you know, and they might even say, using their own language, what's going on with you? What are you trying to tell me? So we're working on the level of interaction, which is very nice work to do if you can get it, of working with mothers and babies together, because we want to prevent problems with insecurity of attachment. In other words, we want these babies to know who their parent is, who their parents are, their other carers. We want to maximise mental well-being, so to prevent things like breakdown of relationships, child separation. If there are external, extended family supports or communities who can help raise children and support them, even in the face of adversity, and there's some great examples of that in our community, then that's very important. We can get better at identifying parents who've got histories of early neglect and issues in their own backgrounds, who might be struggling with direct parenting skills, and they worry about whether they will repeat, and we can offer them specialist support. So we're doing various trainings for some of the very important early childhood centres who are involved in this work. Currently we're involved in doing training at Karitani. We've got a very strong group of psychologists in private practice who are perinatal and infant psychologists who can be very accessible and great support for families. We're upskilling hospital programs so that hospitals, particularly mental health facilities, don't just become focused only on maternal mental health, so that's very important, that's a major component, but can actually think about, well, what are we trying to do in terms of parenting, and how can we improve parenting and reduce risk to child development. So I think that's one of the key messages, that mental health services could be and should be better integrated in terms of a perinatal and infant approach. So having staff who are experienced in working with both adults and children, and the territory of pregnancy and early parenting is absolutely essential. So these are multidisciplinary teams. So we work with maternal child health nurses, early childhood services, and so on, the broad spectrum, psychology, psychiatry, paediatrics to get the sort of support if we need it, and so on. It's fairly broad, as it needs to be. And importantly, we need to have more of these types of approaches in the community where people live. It's not realistic to expect people with new infants to travel miles to hospitals. It's certainly not been possible during the last couple of years with everything that we've been going through. So pleasingly, at least in Victoria, and increasingly it's a model that hopefully gets taken up elsewhere. We will have community hubs for both child mental health and physical health, so access to paediatrics and paediatric nursing, as well as mental health, and having infant mental health and early parenting support based there as well. So I think that's a very positive move. I think there are lots more work we can be doing in this area, but I hope I've given you a sense of the importance of it. And there's plenty of more work to do. More people are having babies at the moment, so that's likely to increase if the world settles down. So we will not be unemployed.